Hello everyone. So we have a 24-year-old healthy person previously, but now brought to the emergency department after an accident. Well, he had a roadside accident, and in the emergency department, patient is alert but anxious and diaphoretic, BP low, pulse high, pupils are equally reactive to light, bilateral chest are best sound are present. Abdomen is distended with rebound tenderness, bowel sound absent, chest issues, rib fractures are there. Then sonography shows a large amount of intraperitoneal fluid, pelvis X-rays negative for fracture. Patient is hypotensive after rapid infusion of 2 liters of intravenous fluid and is taken urgent for laparotomy. Most likely cause of this persistent hypotension is, well, the answer to this question is hepatic laceration. Why this? Why not others? Well, let's learn the basic concept. This patient has most likely hepatic laceration, so-called HL, with blunt abdomen trauma, BAT. Patient has hypotension, BP is persistently low. Chest wall injury is there, right side. Free intraperitoneal fluid is there. Now, the thing is, why it is hepatic laceration, why not other? This is the most common solid organ injured and in BAT, and second best is splenic laceration. Now, you are definitely going to ask me, why not splenic laceration? The reason I'll be telling you little later on. Well, as of now, we talk about HL. This is likely due to the right-sided 8 and 9th rib fractures. Chest X-ray shows several rib fractures, including the right 8 and 9, and these 2 ribs are overlying the liver. So that is going to, when they get fractured, they are going to cause laceration. Other manifestations of HL are right upper quadrant pain, right shoulder pain due to irritation of the phrenic nerve from the hemorrhage. Okay, well, you can see the laceration. Lovely picture. Let me enlarge it. Now, feature which suggests the likelihood of intra-abdominal injury includes seat belt sign, rebound tenderness, abdominal distension and guarding, and concomitant femur fracture. But now I have a question for you. Stop the video, write down the answer. What is seat belt sign? What has been mentioned here? Well, the answer is ecchymosis over the abdomen in the pattern of seat belt. You can see classical thing, beautiful picture, seat belt sign. Let me make it clear now and enlarge the picture. You can see much better now. After that, we talk about after primary survey, patient with BAT should be assessed for presence of intra-abdominal organ injury with the bedside fast and for focused assessment with sonography for trauma. This evaluates both the abdomen and pericardium. Hemodynamically unstable patient with positive fast, that means intraperitoneal fluid, should be taken for exploratory laparotomy immediately. Now let's look into other options. Options C and E, duodenal hematoma and pancreatic laceration. These injuries are in BAT are literally uncommon. So definitely you'll always like to go the best is always hepatic laceration. Now they patient with nausea, vomiting, inability to tolerate oral intake, progressive abdominal pain and sepsis. They all together have different type of presentation. Patient with duodenal hematoma may also have evidence of small bowel obstruction. However, neither duodenal hematoma nor pancreatic transaction are commonly associated with free intraperitoneal fluid. Now the option A is splenic infarction. Point to be noted, in the very beginning I told you there can be hepatic laceration or splenic laceration. But here in the option, examiner is very smart. He has changed the language. It is splenic infarction, not laceration. So spleen is the one of the most frequently injured organ during BAT. The result usually leads to laceration, not infarction as has been mentioned in the option. So, splenic infarction commonly present with left-sided abdominal pain with radiation to shoulder, fever and vomiting. Free fluid is not common unless infarct progresses to hemorrhage and rupture. So this option ruled out. Now look into splenic infarction. In the scan, you can see this is the spleen and normal anatomy, and we now the patient in this we have a right shoulder pain. This is known as Kehr's sign. Why this is? Why we get it? The Kehr sign is, look, these are the diaphragm, they are phrenic nerves, okay, and the referred pain, the tip of the shoulder from subcapsular hematoma, and this typically we see in the left shoulder is Kehr sign, what we call as, all due to referred pain from the phrenic nerve. Let's look into other option. Option B, urinary bladder rupture can occur during BAT, especially in patient with pelvic fracture, which is not there in our case. Patient commonly present with gross hematuria. There may be evidence of intraperitoneal fluid, but somehow, despite that, significant hemodynamic instability is not common. It can happen, but not common. But definitely, this will happen in pelvic fracture, which is not there in our case. There is a fracture of the ribs, not of the pelvis. Well, this is the beautiful picture of these ruptured bladder. You can see here the rupture of the bladder is there. Let me enlarge the picture for you so that better visibility is there. Look into this rupture. Okay. You can see rupture here also. Yeah. Golden lines to remember. Hepatic laceration is one of the most common solid organ injuries during the blunt abdominal trauma. Common manifestations include hypotension, free intraperitoneal fluid, right upper quadrant pain, bruising, and right shoulder pain due to phrenic nerve irritation, what we call as Kehr sign. Thank you very much.